for our next panel, which is going to be coming up in a second. This is our panel providing information about innovations in rural maternal health. As I mentioned earlier, please just come on, you don't need to wait for me. I'm not sure if you're seated in a particular order, but I'm looking forward to learning more about what the landscape looks like when you're not urban, when the resources are more spread out. And these are our experts who are going to help us talk through that.
Hi, everyone. Welcome. Thank you so much for joining us today. My name is Kenna Ho from the Georgia Health Policy Center. We're going to be talking about our rural panel to learn about the rural maternal health innovations happening across our country. And as you engage with rural maternal health providers, patients, partners, and as we think about the uniqueness and complexities of rural communities, we're hoping this session gives you a firsthand look at what it's like to receive and provide maternal care in the rural United States. Today, we will have a group of panelists who are leaders in maternal health who will, let's see, where's my clicker? Here we go. Well, there we go. Who will describe the current state of rural maternal health in the United States and in their specific communities and states. And at the Georgia Health Policy Center, while we work with rural communities to communicate and address their challenges, we also know that there are so many assets and innovations happening and that exist in rural communities that can be adopted and adapted to the rest of the country. So panelists will also share, as we celebrate with them, maternal health innovations and successes that are happening in rural America. So, it is now my privilege to introduce to you our panelists. We have Dr. Kimberly McKay of Avera Medical Group, 69th and Cliff. She's an innovative specialist and an expert in obstetrics and gynecology in the Avera OBGYN service line. Not only does she provide compassionate care for women of all ages, but she also has improved the way care is delivered for attending healthcare professionals. Dr. McKay is also one of the project leaders for South Dakota RMOMs, and we'll share a little bit more about the RMOMs programs later. Shauna Lively, registered nurse, Lamaze certified childbirth educator. Shauna has practiced perinatal nursing for over 40 years in West Virginia, with high-risk obstetric experience, Lamaze certification, and a member of the Lamaze International Board of Directors. She has a broad base of experience in maternity care. She's also currently the project director for West Virginia RMOMs. And Anna Gilbert, former pediatric dietitian in Oregon, and now the telehealth program manager at Maine Health, and part of the Maine RMOMs team. She's been working in Maine since 2019 on projects to increase care team skills and confidence and improve patient access to care. So Lisa Johnson, she's also the project director for Minnesota RMOMs, and unfortunately she couldn't join us today due to unforeseen circumstances, or unplanned circumstances, I should say. But Susan Ninham and Becky Berquist are here today, and they're part of their project. And so I encourage you to connect with them if you want to learn more about their Native American Advisory Council, which is pretty neat as well. So, to get us started, Dr. McKay will provide an overview of rural maternal health in the United States and highlight some of the unique challenges faced by rural communities. So, Dr. McKay, I'll pass it to you.
It's not lost on me that you asked me to do this in Minnesota, where I steal all the public health publications from Dr. Cosmanel about rural health and how I use them as a lever in my own health system. So for those of you from that department, your work is much appreciated. I think rural is one of those definitions. I want to talk a little bit about why innovation matters to us and where it is born and birthed. Rural is, again, it's a definition. Rural is one of those things that you know when you see it. There's a couple of rules in rural. It's non-metro. The federal government has some definitions around it. But in my world, in the practical, and I'm an obstetrician gynecologist, we're not dermatologists. We weren't at the top of our class. We're very practical folk. And in my world, rural means that, small town, couple of gas stations, couple of stoplights, and if you ever stop in a rural town and use the bathroom at the gas station and you don't also buy a pack of gum, you are breaking some rules because you are using water as a resource, which is you can't use for free, right? So that's my definition of rural. I grew up in a small town in western South Dakota called Belle Fourche. It sits almost in Wyoming. There are 5,000 people there now. When I was growing up, I had a high school class of 64, which was large. I remember when our hospital stopped doing deliveries, and it was a really big deal, and that was, I won't even tell you how many years ago that was. Let's talk for a minute not just about rural, because there are rural towns that are a fairly quick drive into a larger center. I will tell you, for the most part, people in rural don't mind driving long distance, except for when they do. But there is even more rural, and there is a definition around that called frontier. And this is going to be these sparsely populated regions. And I think the most important thing to remember about these frontier areas is that they are the highest risk for closure. They are the most isolated. And there is, since 2005, 2004, when we really started looking at this, these are the places that most often close for a number of reasons, and we'll talk about that. I stole this map right from the March of Dimes, who's done some really wonderful compilations around all of the things that affect maternity care in the United States, as in particular around rural care. The red means there's nobody there to deliver babies, and maternity deserts, as defined by having to drive greater than 30 minutes to a maternity center, that can mean a number of different things. But in the Midwest, certainly, it means that you are driving in a wide open space, many times through bad weather, oftentimes through small centers that may or may not have a rural emergency department, who then may or may not be able to deliver your baby if you're driving quickly. So let me tell you about the nail-biting experiences of VBAC from eastern South Dakota that has to drive through a snowstorm to get to a tertiary care center to deliver her baby, and tell you what that is like for them. So for us, this is not just a conversation about data, but my hope today is to really tell you the story of rural and what we experience and how we manage the medical care around it. The other thing I would say is that rurality adds such a layer of complexity and disparity around our minority populations, and in South Dakota, this is our indigenous population that we serve, and have much work to do around repairing relationships and certainly getting patients access to care in a meaningful and culturally respectful way. So a big part of the South Dakota Our Moms grant addresses this. This is South Dakota. This is an interactive map that the March of Dimes maintains on a Deloitte website. But what you'll notice is the purple areas we have, I always forget how many counties we have, a lot. The dark purple, there's no delivering providers. The light purple is where there are hospitals. And what you'll notice is that a county designation from one corner of the county, if the hospital is in the opposite corner of the county, that's probably a 2-hour drive. And in South Dakota, you can cover probably 150 miles in 2 hours if you know the right roads to take, and you do it in the middle of the month when the HP is not out on the highways driving. Yeah, you all do it too, right? So the bottom line is that this map represents the light areas are where South Dakota has hospitals. We don't have very many. What is also interesting about South Dakota in general is that we have basically 4 health systems. We have Avera, we have Sanford, we have on the western side of the state Monument, and then we have our IHS as a provider in our tribal lands. And so we have a unique opportunity to connect. I always say South Dakota is small enough to do great things because we all, at the end of the day, that do this maternal child health work, we all know each other really well. So just a couple of fast facts. Drive times matter. Dr. Cosmanel's work around drive times and increased risk of delivering your baby in a hospital without OB care is real. I happen to work in a health system that is highly integrated, and in every emergency department in our footprint, which includes 33 hospitals, and some that aren't even in our health system. They have a camera in the emergency department, and I have been called more than one time by the emergency department staff to say, hey, someone's delivering a baby. These women also have an increased risk of having an out-of-hospital birth. Now, some people want an out-of-hospital birth, but when you don't want it, in particular in times when you are a high-risk pregnancy and you have many complications, you don't want to be delivering your baby outside of a hospital where there aren't the necessary things to deal with emergencies that come up. The most frequent loss of service is usually in the most remote place. So these are going to be where there's shortages of OB providers and when there are low volumes. Our low volume hospital centers are at great risk because you have many people doing one job. You have nurses that are cross-trained, and they are terrified of making a mistake either on the mother's care or in the baby's care because a poor outcome in a small hospital, of course, in a small town, word travels fast and people immediately lose trust. So there's a lot of pressure on these low volume places. Years ago, I had a consultant come out from Boston to work with our teams on patient quality and safety. And her response to these small centers was, you need to shut them down because their quality can't, they just can't provide the quality. And after I've talked to you about all of these drive times, as she's got to know our health system, she said, actually, probably that's the worst thing you can do. And so our job at Avera Health is really to help lift up these places and put systems in place that are sustainable and that will help the staff feel comfortable providing the care to the patient when they get there. Rural patients, and we see this a lot, are at much higher risk for pregnancy complications. Just as examples, if they hemorrhage, they're at higher risk for blood transfusion, and they have a 9% increased probability of experiencing maternal mortality or morbidity. So these are grave things. Our focus of action at Avera is always around mission and trying to figure out how do we provide sustainable quality care and help our teams feel comfortable providing that same quality and sustainable care. The March of Dimes has a number of things that they've set out in terms of providing and looking at filling gaps in rural facilities, and we chose 3 of them. One of them was around telehealth. I got a lot of telehealth in my shop. We started with dermatology, and it's only, I'm going to pick on the dermatologist today, sorry. I'll try not to anymore, but we have a lot of telehealth. We have a very rich environment for that. COVID, our telehealth went on steroids, and it was of great importance in terms of providing accessible and expert care in rural facilities. We talk a lot about perinatal regionalization, and we started 10 years ago the concept of risk out, risk up. So if your risk as a person who is pregnant going into a facility, if they do not have the resources to care for your potential emergencies, we risk you up to our regional center, and we keep moving up the pathway to make sure that you get to the place and you can deliver where it's the safest to deliver. But also keeping an eye on the importance of keeping deliveries in a small town as well, because when moms come into the big city of Sioux Falls, and Sioux Falls is not a big city, but for us it is, when we come into the city of Sioux Falls for delivery, recognizing that if you're 4 hours away from your 3 children, that there is a financial impact and certainly an emotional impact on that as well. And the last piece is really being attentive to and ministering to those with social determinants of health needs, and looking at those needs in a way that says with the goal of having them have both a healthy pregnancy and beyond. And so these are the discussions that we've entered into with our HRSA partners. I would like to take a minute to invite you to I-90 on February 2nd of this year. For the Minnesotans in the room, I'm going to talk about winter. I'm really sorry. We barely made it through, I know. But this is I-90 in the winter, and you can see from this this shot that this is a road that, how many of you would go above 50 miles an hour on this road? You shouldn't, right? So this is dire, right? And then I want to bring you into that particular type of weather about 11 p.m. In rural South Dakota about 5 years ago, where my team at the Tertiary Care Center of Avera McKinnon, got a phone call from an emergency department physician in one of our rural facilities about 4 hours away. An 18-year-old woman had presented to the emergency department in preterm labor. She'd had prenatal care. I believe she'd had a bit of a history of preterm labor, but there was a snowstorm and she had been at home contracting all day. And when she got to her rural emergency department, she was clearly in labor and now was able to get out of her home, and seek prenatal care. And when they checked her cervix, she was about 4 or 5 centimeters dilated. And as it turns out, she was about 23.5 weeks pregnant. And so our decision at that point is, do we send a NICU team or do we send a maternal team? And at the end of the day, we made the decision we're going to send the NICU team. And the NICU team got there and waited for 2 hours, and there was no baby. There was a mom who was laboring, and there was no baby. And let me tell you the innovation of rural emergency departments. As it turned out, the ultrasound was down, and so they took an x-ray. And the family practice doc calls us and says, the baby's transverse. What do we do? What do you think they did? They didn't break the water. They said, you know what? We're going to send a maternal team. Out of hospital flight time for maternal teams is one of the most important things we consider when taking on transports, because out of hospital time can be brief. And in this instance, it was about 45 minutes, not very long. The other thing that we do in rural is we do some non-evidence-based things that academic medical centers don't like, but we do them anyway because we want to stabilize patients for transport. So we hit this 18-year-old with a large magnesium sulfate bolus. We sent the maternal team to her, and we evacuated her to Vera McKinnon, where we took her down my hallway to room 7, and we were able to keep her pregnant for almost 36 hours so that we could get steroids on board. And ultimately, she did labor, and we were able to section her. I don't know what happened to that baby, but I can tell you this, that there were cameras involved. There were physicians on cameras that did not have privileges in the rural emergency department where they were talking. And there was a really scared nurse on an airplane for about 45 minutes when we got that patient out. But that got me thinking about systems and how do we figure out how to do this stuff really, really well. I'm going to tell you one more rural story so that you understand where my brain goes in terms of putting Lego pieces together. I'm not sure what Lego we're building. I'll let you know in about 5 years. I got another phone call a couple of years later from a doc who had delivered a really low-risk patient. And when he delivered the placenta on this low-risk patient who had just had a beautiful birth, the uterus had come with it. And he called us, and the MFM happened to be on the floor, and the MFM said, well, let's FaceTime. And so they FaceTimed, and he said, don't pull it off. And we worked with the anesthesia team, and we were on FaceTime the whole time as we helped this physician reduce the uterus, push it back up in, get it to clamp back down. And in the meantime, our transport team was sending a helicopter, which was a 20-minute out-of-hospital hop with blood. I'm not sure that that was kosher, but we did it anyway, because you're not supposed to send blood across state lines. But never let a good regulation get in the way of patient care. Right. So as we're using these technologies to address maternal health, this is where Our Moms was born.
Thank you so much, Dr. McKay, for your presentation and for really painting a picture of what it's like to be a birthing individual living in a rural community. So thank you so much. So in response, not to take us down a negative path, hopefully this will be, we need to talk about the hard things, right? But we also want to talk and celebrate the successes and the innovations that are happening as well. So in response to the worsening access to maternity services in rural areas, the Federal Office of Rural Health Policy, which is also a division under HRSA, created the Rural Maternity and Obstetrics Management Strategies Program. That's a mouthful. Also known as Our Moms in 2019. 2019 was like the year of all this maternity funding, wasn't it? The goal of this program is to encourage a range of healthcare providers, obstetricians, maternal fetal medicine specialists, nurse midwives, registered nurses, mental health clinicians, home visiting staff, perinatal support specialists, and others, as well as non-clinical key stakeholders such as state Medicaid offices, social and public services, and academic institutions to form regional networks that can fill gaps in the maternity care continuum. So far, 10 groups in Arkansas, Maine, Minnesota, Missouri, Montana, New Mexico, South Dakota, Texas, and West Virginia have received approximately $36 million in funding. In addition to improving health outcomes for birthing individuals and their babies, the goals of the RMOMS programs are to develop a sustainable network approach to increase the delivery of and access to preconception, prenatal, pregnancy, labor, and delivery of postpartum services, develop a safe delivery environment with the support and access to specialty care for prenatal patients and infants, and develop a sustainable financial model for the provision of maternal and obstetrics in rural communities or hospitals and communities. The RMOM program intends to demonstrate the impact of increased access and continuity of maternal and obstetrics care in rural communities through strategies or approaches that address the following RMOMS focus areas: rural hospital obstetric service aggregation and approaches to risk-appropriate care, network approach to coordinating a continuum of care, and leveraging telehealth and specialty care, and definitely financial sustainability. So we can understand the unique approach each RMOM awardee takes to meet these goals. Our speakers are going to share a little bit more about their RMOMS programs as well. So Dr. McKay, could you get us started and share us a little bit more about South Dakota RMOMS? Oh, it doesn't matter, whatever.
Okay, I'll just stand back up so I can skip through some of these things quick. So South Dakota RMOMS, we were just awarded our grant a year ago. I always like to say it was our third try. I'm going to be thankful for that it was our third try. So thanks, HRSA. We appreciate it. We, just to give you a few fast facts about Avera, we cover a 72,000 square mile footprint. We're focused on our South Dakota footprint right now. We do about 5,500 births per year in 14 hospitals, and we have a terrible nursing workforce shortage in our rural areas, lots of inexperience. Our most common readmissions are severe preeclampsia and mood disorders. 1 in 5 has gestational diabetes. There's about a 9% preterm labor rate, much higher in rural than it is in our what would be considered our urban centers. We have opportunities for prevention around hypoxic ischemic encephalopathy. So for those of you doing the quality and safety work within the hospital walls, you'll see these points that I'm trying to make are really both speaking to where there are opportunities to make change, but also around sustainability. And we also, 2 years ago, came on to the Premier Health and Human Services Perinatal Collaborative Grant. And so we have quite a lot of insight into our own racial and ethnic populations. And we see, of course, the great disparity around our indigenous populations. RMOMS, the concept of the South Dakota RMOMS is to look at clinical care and social programs and services and provide a pathway for us to understand who's getting what and when. And our hope is to increase and improve the access to clinical care and support utilization of social programs and services. Here's our partners. So we have a number of our South Dakota hospitals. I would call attention to our tribal partners and then their healthcare entities, Urban Indian Health and Indian Health Services. And then the great win on this was our getting the state of South Dakota, the Department of Health and Medicaid to the table to just start having these conversations. As you might guess, South Dakota takes a more conservative view on spending around maternal health. And so we are always keeping an eye on how we have that conversation around sustainability and payment. Our guiding principles are to align our work, substantiate it with data, and then figure out a way to meet the triple aim. There are a number of ways to do that like cost savings, cost effectiveness, things like that. But a big piece of what we think is going to be part of our support for these services really around risk mitigation as well within the 4 walls of the hospital. Our Moms program has 3 clinical components. I'm going to talk to you about Avera's role. So care coordination, providing that virtually. A lot of these small hospitals don't have an ability to keep, they're busy. They don't necessarily have time. Remote monitoring. So this is not innovative. It's not new. Getting it paid for is, even though CMS has said, yes, we're going to pay for remote monitoring, Medicaid doesn't always take that same view. And the last piece is the one that I'm going to focus on today, in what I think is sort of a beloved project on mine, is the intrapartum virtual nursing and surveillance hub, using artificial intelligence and things like that to help the people who take care of the moms and the babies work smarter, not harder. So we'll go through, so we did, our remote monitoring is really around hypertension. Our virtual care coordination is looking at medical risk assessments and maternal mental health. One of our big projects coming out of this is IT connections with both the state of South Dakota and Department of Health. I see people nodding their heads so that the right hand and the left hand are communicating. And then the last piece is looking at financial stewardship around obstetrics and looking at the cost of medical malpractice for these small hospitals and for our own, within our own system. So let's just talk a minute about our remote monitoring hub. The goal with this, and there's a lot of things, this is always looked at through the eyes of equity, and I'm being much in the quality and safety world right now and not into the heartstrings of equity, but just know that what we're doing is looked at through the lens of equity, and now that we're in the habit of it, my hope is that as we get through these programs, we don't have to say, why aren't people doing X? That we've been able to account for all of those things. But the big piece around this is our small hospitals have nurses who aren't comfortable taking care of higher risk conditions. So the idea is we put a software system in that can do surveillance, both around maternal vital signs and fetal heart rate conditions, and that when a patient is crossing abnormals and the team doesn't recognize it, the AI within the software is helping our virtual nurse either reach out to teams to say, hey, did you notice? Or B, how can I help? And so we know, again, some of the quality metrics coming down from the Joint Commission on time to treatment with hypertension, which we know makes a difference. Sepsis is another really big one that we can impact within the 4 walls of the hospital. What we're really trying to do is, again, use software as a workforce support tool to help teams take care of these medical conditions smarter. So I'm going to just connect the dots really quickly for you. Here's a current state. This is an actual patient, 29-year-old, presented to her hospital not feeling well. She was itchy. She had liver functions tests. And the current standard of care is that the hospital MD talked to the maternal fetal medicine specialist who accepted the transport with a working diagnosis of cholestasis and the plan to transport her by ground. Ground transport does not always involve a maternal nurse, so this patient was sent by ground. And when she got there, she was found to have a diagnosis of acute fatty liver pregnancy, which is a medical emergency. So that would have been nice to know ahead of time. Fortunately, the patient did very, very well, but certainly our current telephone game that we play with transports is not helpful. So how do we lever the technology? This is where the transfer nurse, the OB nurse, comes in and says, we're going to do the intake, we're going to look at the strip, we're going to look at the heart tones in the lab, and we're going to recognize that condition before we even make a decision on transport. And then we're going to make a decision about how we transport that patient as quickly as possible. So that's going to be our new workflow moving forward. And I think I'm going to skip the rest of these so that I don't take up too much time. So it's a big, we can ask questions. I know. Oh, you are? Okay, great. Steal away. All right. Okay.
Okay, about the Barbie shirt, I have to explain, okay? And it's all her fault. It was in an email, and she'd just seen the Barbie movie, and she was like, oh, I am so about this. We are going to, let's wear pink. And so I was like, yeah, I'm totally into pink. I love pink. It's my favorite color, aside from all the other colors. And then she was like, I have a Barbie shirt. I was like, oh, I can't be outdone. I'm going to get me a Barbie shirt. So I could get on Amazon and order my Barbie shirt. I'm going to wear the Barbie shirt. Okay. And a blazer. Okay. So guess what? It's kind of like being invited to a Halloween party and told it's a dress up party. And then you're the only one in a costume. But I want you to know my Barbie shirt has Barbies of various professions and colors, so she's an inclusive Barbie. So, yeah.
It demonstrates how close our moms both are with each other.
But that's okay. It's all right. Yeah, I used to play with Barbies. My first Barbie, I was just saying that she was not white. She was not black. She was some kind of brown. And then my Ken was like that too. And I thought, you know, that's interesting because my husband was that color later on. And like maybe it kind of, anyway, I digress. So our moms has been fantastic. We, let me see how to advance this. Okay. So we are West Virginia, our moms. And the West Virginia Perinatal Partnership is the perinatal collaborative, the quality collaborative in West Virginia. We were established in about 2006, long before the other collaboratives. Let me tell you that. We were number one, or one of the first ones, okay. And our mission is to engage all the providers because we thought we were in silos. You know, we looked at this and we said, how come our preterm birth rate is high? How come we're having all these complications? How come the diabetes rate is high? So we needed to get together and we needed to break the silos. We had Marshall University over in Huntington. We had WVU up in Morgantown, and, you know, the state NCAMC in Charleston Area Medical Center. So all three of these hubs were, you know, in silos. How can you break that? Well, you bring people together. That's how you can break those silos. So we are the Perinatal Collaborative. And just to give you a background about West Virginia and where we were, we have a little over 18,000 births per year. It's pretty small. And like in most states, our birth rate is declining almost every year. We have high rates of obesity, diabetes, hypertension, cardiovascular disease. And as you learned yesterday from Janine Brile and the team, high rates of substance use disorder. We've been working, she's had a thank you Janine, she's right there, had some good success with treatment of that population. Our population is mainly white with about 10% non-white. Our main disparity in the state is poverty, although we do have to dig deeper into our other populations. So here's a picture of West Virginia, and see all those hospitals there? In 1976, I don't know where you were in 1976, but many of you, as I can tell, you were a glimmer in your daddy's eye because you weren't even here yet. But in 1976, I was in nursing school, and I was practicing as a nursing assistant in one of those little hospitals. But look at that, and now, look where we are now. Put your hand right in the middle of West Virginia. There's no OB care there, no maternity care. And like Dr. McKay was saying, the problem is that people don't, you know, there's not a lot of people there. There's not a lot of business there. So all these hospitals closed or closed their delivering facility. Here's a drive time map. So you can see where the hospitals are there, and that little white area, that would be probably more than 2 hours drive. And we're talking about a mountainous region. And it's, you know, 2-lane roads, mountain in February. It snows in West Virginia. Okay. So I just wanted to give you a little bird's eye view of where we were and where we are. And these are the things that HRSA wanted us to do. Number one, of course, improve maternal and infant outcomes. And to do that, develop a sustainable network of care. How can we help each other and break down those silos? The other one is develop a safe delivery environment and access to specialty care. How can we get the specialty care into these areas? You know, we have probably about 4 maternal fetal medicine specialists in the state. So they can't be everywhere. And to develop sustainable financing models, because we know if it's not sustainable, if we can't pay for it, it's going to go away. And I don't want it to go away. I want it to stay. This is all too busy slide, but I wanted to put it out. And then if any of you are interested, I can email you my PowerPoint. But the number one goal, of course, is to improve the outcomes. So we're working on smoke cessation. And the reason I was telling you a lot about the perinatal partnership is that for years since '09, I had been the outreach education director, because what we felt is the nurses and doctors really needed to have support. So what we did is set up fetal monitoring, A1 fetal monitoring courses throughout the state and go to various regions and hold them. We had a Lamaze childbirth education, evidence-based labor support for labor and delivery nurses. And we'd bring all those birthing balls and everything and leave them at their hospitals, so it was all kinds of fun. We established a lactation alliance, you know, West Virginia Breastfeeding Alliance. We have that. And that is for, all of this education is for providers, so the providers and caretakers can access all of this. And we have to decrease our C-section rate. It's about the 7th highest in the nation. Our preterm birth rate is about 12%. So yeah, we have a little bit of work to do, don't we? We leverage things such as Count the Kicks. We're partners with them. We have funding that if you go on Count the Kicks website, if you don't know about that, it's stillbirth prevention. And we can, you can download information from there. You can also download a free app. If everybody would have a free app on their phone and show their patients, you can have this free app of counting kicks, you know, in the last trimester of your pregnancy. That's totally awesome. And then we have our Baby Safe and Sound that we fund too. So we have all these resources, but they're no good if they're just in those centers that we have maternity care. We have to, you know, if I'm bringing providers to these places, we have to have those support things. Okay, develop a safe delivery environment. Now this is my passion right here. Yeah, you can have OB services, you can have midwives, you can have obstetricians, maternal fetal medicine people. That's great. However, we have to lift these women up with support. They have to have someone that helps them through, like a patient navigator or like a community health worker or, you know, someone to talk to. Substance use, you know, peer counselor. So we have in our projects, we funded patient navigators. We are going to have an OB day in Summersville, where one of the maternity units has closed, and they have an armory there. We're bringing EMS, all the obstetricians we can gather up, and all the people that touch pregnant women in our FQHCs around, and we're bringing them to one site to have a giant skills day and bringing our mannequins that, you know, bleed and throw up and have babies and all that wonderful stuff. Love that kind of thing. And teach people a little bit about emergency birth and about what to do in case of a complication. And 3, develop a sustainable network of maternity care providers and delivering facilities. So here we are. we have plans in progress, and this is what I'm in my year 2. The first year was planning. The second year is doing something. So we put people in place throughout the state, or throughout the 8-county region, rather, and we are doing midwives in a few places, nurse practitioners in a few places, and in Summersville, we have an OB that comes 1 day a week. At Davis Hospital, they have, well, the other thing, I don't know if you guys are affected by this, but every time I stick my head out the door and go to my 8-county area, there's another affiliation, acquisition, or something. These health systems change all the time. So anyway, Webster, which is a county of mine, they're very rural. They have Cowan Clinic, and they were able, in an adjoining county, to put a certified nurse midwife 1 day a week into the Cowan Clinic. This is a very rural area. We have Braxton Memorial Hospital, another area. We have an OBGYN there 1 day a week, and we've supplied her with ultrasound equipment so that she can properly take care of the women that show up there. She's also in Summersville 1 day a week. So that's really interesting. We have New River Health and FQHC that we've put a nurse practitioner in, and then an OB provider 1 day a week. We've nudged and encouraged. You know, when I got this grant, I thought, oh gosh, $4 million. This is totally awesome. I'm a nurse. I've never even seen $4 million before. This is awesome. And then it's like, well, okay, $1 million a year for 4 years. Okay, I get that. And then over 8 counties. If I didn't have the partnership, the quality collaborative, you know, I wouldn't be able to do all this, to really leverage all of these things. And yeah, I pull in A1, ACOG, the midwife organization, everybody that I can think of to play in our sandbox. So more on that later. But so we have the providers in place. So I like this slide because medical care affects about 20% of overall health. And behaviors, what we do or don't do, drugs, overeating, smoking, and in my case, lack of exercise, affect about 30%. And then the social determinants of health, 50%. So I think, wow, you know, housing, food insecurity, all of that, you know, goes into our health, our own health. So our optimal level of functioning requires a lot of support for moms, for dads, for babies, for families. And how can we keep this up? Well, the partnership, again, has met quarterly with the Medicaid payers and our public insurance, public employees insurance. And it's really a good time for us to discuss, you know, are you going to provide for breast pumps? Well, once we started saying, yeah, you need to provide breast pumps for these women, then they did. You know, so we go back to them, are you going to cover these conditions? Yeah, you know, so, and I made a plea the last time, how about doulas? Can we just cover doula care? So they're working on it now. I got a Unicare grant for over $100,000 to provide doula education and networking and build the doula workforce in West Virginia. We just got that about a year ago. So now we have trained 80 doulas. Yes. It's so important. So anyway, what I think the data will show is we have the support services and we have appropriate risk medical management, being born at the right place. And, you know, once they risk out, you know, they need to be delivered at a tertiary medical center. I think that this is going to decrease cost. I think it's going to make a difference. So this is what we're all about. This is my passion. When, you know, Janine and Amy and those folks, they're really smart. They wrote the important parts of the grant that you want to look at, you know, about all of the data and, who lives in these counties, and they crunched all this stuff. And they said, okay, Shauna, you write the clinical part, what you want to do. Well, I took my years of experience, over 4 decades of it, and wrote to my heart's content. So I wrote in everything I could think of that we were going to do. And so submitted thinking, this is never going to happen. We are not going to get this. So I'm going down the road, literally 80 miles an hour, down a curvy road. We have curvy roads. And Janine calls me and says, guess what I found? You got the grant. I was like, oh my gosh. So isn't that wonderful? Oh God, now what I'm going to do? So, it's kind of the old crap. Yeah. So bringing everyone together again, I think has been an incredible experience. And I wanted to show you a success story that we had. We have a woman in the Cowan Clinic, and about 2 hours away or so, maybe 2.5 hours from Charleston. And she delivered her second baby at the Summersville Regional Medical Center. And that was only maybe 30 minutes from her house. I'm sorry, first baby. Second baby, she was pregnant. She was like 37 weeks, and they closed the delivering suite of the hospital. So she was scared out of her mind. She went to Charleston Area Medical Center, delivered the baby. Everything was good, but she was so scared. She didn't know anybody, and to have to change providers and hospitals and everything right in the middle, it was awful for her. But third baby, she gets to go to the Cowan Clinic, and I asked her, I said, what was the most important? Well, the midwives. They really took good care of me. I didn't have to go far away from my home for care. And she said, I got to not miss work. I said, well, what do you do? She said, I'm a home health worker. And so all the elderly people that she was taking care of, she got to provide care for. That would have been, OB care, 10 to 16 visits. That would have been 10 to 16 days missed of work, So that was a success for her. And she was taking care of her family, earning an income, breastfeeding her baby, and it was a very good outcome. This is what I want for the people in West Virginia. And there's our iconic New River Gorge Bridge. Come and see us at the New River Gorge, our latest national park. But my theme is we rise by lifting each other. Anna, it's all yours.
Thank you. Ooh, okay, so my name is Anna Gilbert, and I am a telehealth program manager at Maine Health. And in September of 2022, Maine Health was awarded the Our Moms grant to administer across the state. So a little bit about Maine. So Maine is a big, beautiful state. It's the biggest state in New England. It's also the most rural state in the country. So just over 61% of our population live in rural communities. So this makes for a state that's full of these little tiny, amazing towns. But it also makes for some challenges for the approximately 12,000 births that happen per year if you're not living near a birthing hospital. So some of the challenges, that we see in Maine, like other places in the country, our birthing units are closing. So just in the last 2 years, 4 of our birthing units have closed, and we've identified several others that are at risk of closing. Like what's been mentioned before, our patients are driving long distances to get to care. So there was a birthing unit in the northernmost part of the state, right at the Canadian border in Fort Kent, that closed in May. And then the next closest birthing unit is in Caribou, Maine, which is a 50-minute drive with good weather. We get blizzards, snowstorms all winter long, so that can really impact how patients get to care. There's huge transportation issues. Every single practice that we've talked to said that
their patients struggle with getting to the clinic, physically getting there. So patients have limited personal transportation options, and then in our rural communities, there's like almost no public transportation. It's very limited. And then there's just a limited number of specialists in our state. There's only 1.3 million people in the state, and so for example, we have 3.5 maternal fetal medicine physicians, and they're all in Portland. So Portland is in the very southern part of the state. So if you're coming from Fort Kent, it's a 5-hour drive. And then we just have difficulty recruiting. I know you talked about that in South Dakota, the nursing shortage, the same thing as in Maine. So birthing units are hiring new nursing students, and then there's the training that has to take place with that. And these nurses are often not just working as OB nurses, because the hospital that they're working at might have 50 or 100 births per year, so they're floating to other departments. And then we just have difficulty recruiting new OBs as well, because at a small hospital, you don't have the mentorship opportunities and the training opportunities that you do at a larger facility. So like I was saying, birth rates can be quite low at hospitals, and so these OB teams aren't getting that exposure to, you know, the low occurrence, high risk events where it's really important to be to have those skills. So this is a little map of Maine, kind of talking about where our care is located. So all of the X's are the non-birthing hospitals in the state, and the dots are where there are birthing facilities. And so Eastern Maine Medical Center is in Bangor, and Maine Medical Center is down in Portland, and those are your two locations if you need to access a NICU or you need a higher level of OB care. And so if you're living in the southern part of the state, you have slightly better access to healthcare. If you're living in the northern part of the state, it gets really limited. So that kind of brings us to why we applied for this grant, and it's all about access for our rural patients. So, you know, we're looking for innovative ways to connect those patients who don't have transportation issues, who are living far away, so that they can still access their healthcare teams and have safe births and pregnancies. We're really hoping to prevent further closures, because every time a hospital closes in a community or they close their OB unit in a community, the care for all of those people in that community is displaced. We really want to increase the retention and recruitment of our OB care teams to our rural hospitals. We want to improve our rates of maternal morbidity and mortality. And then we just want to help connect the hospitals throughout the state. A lot of them are still independent hospitals. There's 2 large health systems in our state that provide OB services, and then there's 5 independent hospitals still, and they're often kind of feeling like they're in their silos. So we were really lucky with this grant. We've been able to bring together all 16 of the rural birthing hospitals into our grant, and then we've also been able to bring in a number of state organizations and partners. So for the first time, you know, these hospitals are able to connect with each other regularly. They're able to troubleshoot. They're able to share experience. We just had in our last network meeting, which we have monthly, an OB who was sharing a story about a pregnant patient who was also having an eating disorder. And there was another hospital who had recently had the same issue, and they were able to kind of talk about what they were able to do for that patient. So for our grant, you know, we kind of have 4 pillars that we're using as our lens to develop all of our programs through for this grant. And so those are telehealth, building capacity, data, and assessment. And so, you know, we took a lot of time at the beginning of the grant. We're just coming to the end of our year 1, which will actually end at the end of this month, which is totally bananas. But so we spent a lot of time talking with all of our hospitals, meeting with them one-on-one, following up with them, and we really came to see that the top needs of these hospitals were the clear front runner was mental health support. So in our rural communities, there can be very limited mental health services. Pregnant patients, postpartum patients who are screening positive for depression are put on wait lists that are anywhere from 2 to 9 months before they're seen. Hypertension was the second runner-up, followed by diabetes, and then opportunities for training and education for the OB care team members. So all of the projects that we've slotted for the next 3 years of the grant are all focusing on that, and we've been able to get really great participation from our networks because we've listened to what they wanted so closely, and so we've just launched a remote patient monitoring work group for OB hypertension, and we have representation from 6 different organizations on that work group. So that felt like a really big win, and that's my little piece about Maine. There's a lot of overlap with what was presented earlier, but I think these are common common things that we have to solve for in our rural communities, and it's really important because those patients deserve the same level of care as everyone, even if it might be that they're living in a rural area. So thank you.
All right, thank you ladies so much for providing an overview of your RMOMS program. In the last few minutes we have, the audience does want to hear a little bit more advice and some of your experiences about how you built your RMOMS network. So Dr. McKay, maybe in a minute or so, what's maybe one piece of advice you could share with the audience about how you would effectively work with rural communities, so in terms of engaging providers, patients, or even partners to keep in mind?
I mean, I think the same thing that we've heard throughout. Don't assume that you understand the world that you're stepping into, and also don't assume that you're going to go in and fix everything. You're going in as a partner to understand where you can fit in the solution. You might not find that the solution was what you planned, but you want it to be the right solution.
No worries. And then, Shauna, you spoke about your state's perinatal quality collaborative. Could you tell us more about this resource and maybe how it's been imperative to your work in as quickly as possible?
Just reach out to your PQCs and your other organizations like ACOG, A1, nurse midwives. Reach out, and that's how you break down the silos.
And I did see that there are several states across the country that have perinatal quality collaboratives. I was Googling it after you mentioned it last night, and I'm like, oh, look at that. Lots of states have them. And then, Anna, you spoke a lot about your RMOMS network is working to improve the management of chronic care conditions, hypertension, gestational diabetes, and whatnot, maternal mental health through technology, telehealth technology. So could you tell us what are some of the promising innovations that your network is planning around telehealth?
Yeah, so I think telehealth is, a really powerful tool that can be used in many different ways, but especially in our rural communities to connect patients to specialists. The 5-hour drive to see our maternal fetal medicine providers can be eliminated so people can stay in their communities and stay with their families. And so really trying to think of ways and following examples of other telehealth programs that are up and running throughout the United States and doing a great job at connecting patients.
Oh. All right. Well, thank you so much, everyone. We know you're all hungry. And thank you to our presenters for sharing more about these innovations and successes happening in their rural communities to build a better future for birthing people. Thank you. And there's our contact information as well if you'd like to connect.